Okay, so continuing on here with part two, and if this goes a little bit longer than 20 minutes, I apologize. Hopefully, it's some really interesting stuff. Case control studies. So now looking at some of the kind of not cohort yet, but we're going to be comparing a couple different cohorts. These provide a relatively cheap way to investigate causes of disease or injury, especially for a rare disease. So, in a cohort study, which we will take a look at again here, in a cohort study or an incidence study, you may not be able to capture enough of that rare condition, or you may have to wait forever for an occurrence to happen. And a cross-sectional study isn't a great way to see about different potential causes of disease, of a rare disease, because you may not be able to capture the presence of that rare disease when you collect your data at that point in time. So in a case control study, these studies include people with the disease or outcome variable of interest and a control population. So it is a comparison or a reference group. And those individuals do not have that disease. Now, this type of study compares the occurrence of the possible cause in cases and controls. Researchers collect data on disease occurrence at one point in time and exposures at a previous point in time. So how does this work? First, there is the selection of cases and controls. Cases are selected based on disease presence and not the exposure. So we're not looking at individuals with the mindset, oh, we're looking for people that have been exposed to things we might think could cause cancer. Rather, we're looking at the people who already have the disease of cancer. The controls are people then without that disease. So the most difficult task is to select controls so as to sample the exposure prevalence in the population that generated the cases. You wouldn't want to do a case control study of a cancer diagnosis utilizing people in the United States who might be exposed to a variety of different cancer-causing agents and compare them to a cohort of individuals living in an island country, not Hawaii, but some other island country that has none of the same industrial hazards that we might find within the United States. Here's what a case control study looks like. We've got our cases, people with the disease, and our controls, people without the disease. And then we go back and we look at a particular exposure of interest and then try to categorize how many or get the percentages of how many are exposed and not exposed in each group. So, in this case control example from our textbook, researchers in Papua New Guinea compared the history of meat consumption in people who had enteritis necroticans, and I probably pronounced that incorrectly, with people who did not have the disease. Proportionally, more people who had the disease reported prior meat consumption than those who were not affected. So how did they find this information out? They interviewed people. So they had the cases. They had 61 people who had the disease, and they had 57 people who did not have the disease, and then they found out what percentage of individuals in each group had eaten or had prior meat consumption. Another case control study example, this one discovered the relationship between thalidomide and limb defects in babies born in Germany. The study compared affected children with normal children. Of the 46 mothers who had babies with malformations, 41 had been given thalidomide during weeks 4 and 9 of their pregnancy. None of the 300 mothers in the control group had taken the drug. So, what was necessary? knowing from the interviews if people had had exposure to the medication, and also appreciating the timing of drug intake, so understanding what that exposure was. Why do you think case control studies like this are valuable? Because it would be unethical if you think thalidomide causes birth defects to do a prospective cohort study giving the drug to pregnant mothers to see if babies were then born 8.5 months, 9 months later with defects. Cohort studies now, these incidence studies begin with a group of people who are disease or injury free, and then you put people into groups based upon their exposure. My examples a lot of times are grouping people based upon their preseason presentation. So, do they present with a certain fitness level, or are they maybe at risk, or we are hypothesizing they are at risk because their fitness level is not as good? Variables of interest are specified and measured, and the whole cohort is followed over time to see what the percentage of new cases of disease or injury are in the groups. We'll see a nice example of that in just a bit. Now, these types of studies provide the best information about causation of disease and the most direct measurement of the risk of developing disease. But these are major undertakings and they require a lot of time. For example, how long do you have to follow people for after they've been exposed to radiation to see if they develop leukemia? That would take a long time. Here's what a cohort study looks like. I've done a lot of these, but my time periods are short. I look at people at the start of the season, and then I follow them over the course of their season. So think about this population. Maybe these are all the D3 athletes in the United States that play basketball. Now, the people without the disease are maybe the D3 basketball athletes that I can recruit within my region of Portland, Oregon. And then we have two groups, an exposed group and a non-exposed group. What does that mean? Well, it's how we categorize them. For example, this could be the exposed group could be people with poor fitness compared to the non-exposed group being people with better fitness by whatever measure you're using. Or, like I gave an example in Screencast 1, I could have hypothesized that forwards were at greater risk than non-forwards. So again, here's another way of looking at it. Population without the disease, we've got our exposed, or we can call this the group that we are hypothesizing to be at greater risk, and the not exposed, the people who are at lesser risk. We collect this all in the present at baseline, and we follow them into the future, and we take a look and see what percentage of cases occur. What percentage are people having the disease or injury in each group? So an example here, looking at 200 high school female basketball players without ACL injury history and looking to see what their quadricep to hamstring strength ratio is. One group was considered abnormal. That's our at-risk group. And then the other group is the normal group. And we see that 50% of them had ACL injuries in this group, whereas only 20% had them in this group. Here's one of my studies where I had 106 Division III female athletes without injury. This group here had all four functional tests. The performance on all four functional tests were below average. Their scores were below average, whereas this group here consisted of those who had maybe good test scores, or maybe three of the four functional tests were below average. So what did we find? Well, 5 of 14 people that were in this group, 14 people were considered at risk. 5 of 14 went on to have a non-contact time loss injury, whereas only 5 out of the 92 in this group went on to have a non-contact time loss injury. So people in this group were at a greater risk. Cohort studies, there is the prospective way. The cohort is assembled in the present and followed into the future. And a great example of that is the Framingham study. A retrospective cohort identified from past records and followed forward in time up to the present. Studies that utilize large data sets from computerized medical databases can really help you do great things with retrospective cohorts. What's the Framingham study again? For those who may not be aware of it, it's that long-term ongoing study looking at residents in Framingham, Massachusetts, started in 1948 and is continually following people over time to look at risk factors associated with heart disease. This is a little old now, maybe a few years old, but it gives you some perspective of the numbers of studies generated. So this is a major, major undertaking, but it illustrated 1960, the year that cigarette smoking was identified as a risk factor of heart disease. Interestingly, I talked to my cardiopulmonary class students. If you go back and look at autopsies of those Americans killed in the Korean conflict, one study found 75% of these individuals, mean age was 22 years of age, 75% had signs of coronary artery disease at an age of 22. But it wasn't until years later that we identified that smoking was a significant risk factor of heart disease. Look at the number of published papers from this major epidemiologic study. This is not the type of thing that you should be doing for your dissertation, obviously. This is a major, major undertaking, millions and millions of dollars, tons of people involved in this study. Now, prospective cohort studies can assess purported risk factors not usually captured in medical records. Researchers are able to collect info about confounders, and data collection can be standardized to decrease measurement bias. Retrospective cohort studies, again, like I mentioned before, you utilize information that was already collected by somebody else. And so as a result, these studies take less time, they're less expensive, they're much easier to perform, but they cannot undertake a study of factors not recorded in that database. And there's a possibility of bias if the data was not collected in a standardized manner. Well, what does a retrospective cohort study look like? Well, basically, it's like this. You are in the present. You don't know yet what groups these are in. You just know that in the present, some of the people that you're working with have the disease or injury and others do not. You go back in time. See, number one here, we go back in time and we collect, or we look at this data that was collected when people were disease-free or injury-free at that beginning time period, and then we put them into groups, at-risk and lesser-risk groups, based upon whatever we're interested in looking at, and then we go back to the present, and this is where we can get these proportions in to find out what percentage got the disease in each group or the injury in each group. And here's an example. So let's say you work in a skilled nursing facility, and you've noticed that there's been falls that have occurred, and you would like to know why these falls are occurring in your skilled nursing facility. So this is a made-up example, made up everything. Let's say upon intake, everybody was evaluated for their ankle stability. Well, you could go back when everybody was admitted, so they hadn't had a fall when they came to you, right? But you did collect ankle stability measures, and so you found that there was a group that had poor ankle stability, and you found that there was a group that had good ankle stability. So now from that past data, you've been able to dichotomize people into one group or the other, and then you can move forward into the present to find that 60% of those with poor ankle stability had a fall, whereas only 10% didn't. And if you were to run the numbers, you would find that those individuals with poor ankle stability were at a greater risk of injury. I'm not going to read through this. You can kind of peek at it as you'd like, but basically it highlights the strengths and limitations of prospective studies versus retrospective and case control. Now, retrospective and case control are combined here in this because there's similarities to them, but they are not the same. Very important to make sure that you're not confusing retrospective cohorts with case control. Remember, case controls, do go back in time to take a look at potential exposures, but the difference is you've got a group with cases already and a group of controls. Whereas with a retrospective cohort study, you go back in time when nobody had that disease or injury of interest, then you dichotomize them, you categorize them into one group or the other, and then you're able to see if there was a risk factor associated from that assembled cohort from the past. Here's a summary of strengths of epidemiologic studies, or even if they're not suitable, and the particular objective that you're going for. Won't read through these. If you want to take a look at this, you can go ahead and do so, but it's just for you to kind of be aware of what is the best way. And as we can see there, case control studies are a great way for those rare diseases. Again, why is that? Because a rare disease is hard to capture if you're doing something cohort or cross-sectional in nature. Again, here's another advantages and disadvantages of observational study designs, looking at potential things like bias, time required, cost, loss to follow-up. Look at the cohort. Very costly, a lot of time required to do that. What about a case control? Not as costly, not as much time required. You don't lose anybody to follow up. That makes perfect sense because you already know people at baseline what's been going on. Potential issue of recall bias. When you're asking somebody, were you exposed to something in the past? Does that make sense? They may think that they were, but maybe they weren't. So now experimental studies. So remember, we have observational studies and experimental. And again, the way that another slide illustrated it, we've got the experimental side and the non-experimental side. So the experimental side, you can do experimental studies and have or apply epidemiologic methods. And a lot of times what you're trying to do is to see if you reduce the risk of injury or reduce the risk of disease. Here's some examples of study designs. You've probably talked about some of these in your other research method classes. So in experimental epidemiology, the intervention or experimentation involves attempting to change a variable in one or more groups of people. For example, elimination of a dietary factor thought to cause an allergy. Does elimination of that help to reduce that allergy in a group compared to the control? Or testing a new treatment on a selected group of patients. Does it improve outcomes or reduce disease? The effects of an intervention are measured by comparing the outcome in the experimental group, again, with that control group. So, randomized control trial. And epidemiologic experiments designed to study the effects of a particular intervention, usually a treatment for a specific disease. Subjects in the study population are randomly allocated to intervention and control groups, and the results are assessed by comparing outcomes. Field trials involve people who are healthy but presumed to be at risk. Data collection takes place in the field, usually among non-institutionalized people in the general population. So we're going to see that illustrated in the next figure. Subjects are disease-free or injury-free, and the purpose is to prevent diseases or injuries that may occur with relatively low frequency. Field trials are often logistically complicated and expensive. So here is an example of that. What does this look like? It looks a lot like our prospective cohort study design, doesn't it? Here's a great example. Now, those of you who are physical therapists or athletic trainers may be aware of this study. So in this particular study, this was a very valuable study. ACL injuries happen all the time, and there is the recognition that they occur more often in female athletes than in male athletes. So what did this study do? Well, this study randomized teams of athletes to one of three groups. Actually, one group wasn't randomized. There was a control group of male athletes because male athletes are at a lower risk. So they were curious, could our intervention create a similar risk profile in female athletes that it does in males? So there were three groups. The randomization occurred in the two groups of females. There was a group of females who received the intervention, which was the neuromuscular training program. And then there was the other group of female athletes who just trained per usual. And then finally, there were male athletes, and they just trained per usual. They did not participate in the neuromuscular training program. So what did they find? They found that untrained female athletes had a 3.6 times higher incidence of knee injury than trained female athletes and a 4.8 times higher rate than male athletes. What that looked like to you? Epidemiologic data, people at risk, more likely at risk. So what they showed was essentially those female athletes who participated and trained with that neuromuscular training program, their risk of injury decreased, and it was now equivalent to male athletes. Very, very important study that also led to additional studies on the topic. Of course, this was a field trial. You had the randomization that occurred. But what was epidemiologic in it is when you start to see details about the serious knee injuries, how they occurred. So that richness of data is very valuable. And then, of course, we see presentation of injury incidence or these injury rates per 1,000 exposures. Community trials, these are treatment groups consisting of communities rather than individuals. These are appropriate for diseases that are influenced by social conditions and for which prevention efforts target group behavior. So an example of this is related to cardiovascular disease here on this slide from box 3.6. I'm not going to read through this one, but what I'm going to do is give you time to pause the recording to read through this to get a sense of a community trial. So go ahead and pause the recording now. All right, so I assume you've had a chance to read that. Let's continue on the last few slides. Now, something I'd like you to do is, and you've probably talked about these already within your other research method classes. So I'm not going to exhaust time here going through this, but what I'd like you to do is review potential errors in epidemiologic studies. And again, these types of things you're probably familiar with from general research methods classes. So go to page 52 to take a look at those. Confounding can be an issue, right? And why do I say that? Confounding, just as a specific example to highlight here, you should read through on page 55, but confounding is an issue you've got to think about within epidemiology, because what if you think about, let's say, is there a relationship between coffee drinking and heart disease? And you had a group of people, and you had one group that was the coffee drinkers, they were at risk, and the other group was the non-coffee drinkers, and you thought they were at a lesser risk, and you go through and you find that the coffee drinkers are at greater risk for heart disease. Well, were they actually at a greater risk? What could be a confounding variable? Sometimes people, when they have their coffee, they like to have a cigarette or they like to use tobacco. So were those individuals who were coffee drinkers also people that used tobacco? The tobacco is the confounding variable. If you didn't consider that, your study would have been flawed. Now, to control confounding, take a look at page 56, review through that, and that's all the more time I think we need to give to that within this lecture. Remember, you've got your discussion response. Please respond to your classmates. You're going to review their prevalence and incidence examples. They presented those in the first forum in week number 2. I'd like you to provide responses to a minimum of 2 of your fellow classmates. For each response, you're either going to ask a question that's directed towards further developing one's sample study topic, or identify and share literature that is similar to your proposed topic. Now, asking a question is a great way to go because There is diversity in this group, and so by asking a question that may inspire additional thinking from your classmate, or if you're working with somebody or talking with somebody that shares your discipline, you might ask them, hey, were you familiar with this particular study and what they looked at here? Or, hey, I like your idea. Are you familiar with X, Y, and Z? So this is an opportunity for us to kind of work together and learn together. You also have a homework assignment. And again, you're going to need to be able to access 3 articles to answer your homework questions. Have a great week.